So hello everyone, good morning. I'm gonna just try to figure out this clicker thing. Sure. Okay, it works. So my name is Jeffrey Hernandez. Thank you guys for coming back from the break. I'm happy to see that you didn't skedaddle. My name is Jeffrey Hernandez. I'm from the University of Miami. I've been there for a total of 14 years. Briefly, I was an MA. I started off as an MA, then became the RN, the MSRN, and then the NP. And so we've been there for a long time, and I'm happy to still be there after so many years and working with the team. And I'm a certified nurse. So if you guys haven't taken the course or the testing, please consider that. It will reinforce and support your level of knowledge in MS care. So the way that I formatted this presentation today is a little bit different than last year. And to kind of help give you a visual and the process of diagnosing someone with MS, particularly a man, and then give you the foundation or the initial knowledge of the different aspects of the history, the exam, the MRI, and then the treatment plan, okay? So this is a 31-year-old man. He's new to me. I've seen him for the last year. Prior to that, he's been seen by 2 other neurologists in my group, and he's decided to stay with me. He initially started in 2015 with symptoms, so prior to the diagnosis. He was 23 years old, and he was in Venezuela. He moved from Venezuela to the United States. And his father-in-law, he said, noted that he was walking differently. I'm not sure that he was a father-in-law at that time. He wasn't married that young, but he said that he was walking differently. A year later, so in 2016, at 24, he noticed that he was having issues with the right leg, especially when he was running. He was very athletic. He was a very active person, he says. With long-distance running, he started to fall to the right. Later that year, he even noticed that walking a long distance, for example, at the mall, he said, he would start to have loss of balance, some leg weakness, that he just couldn't make it. He had to take a break. And then a year later, unfortunately, he started to experience falls due to the right leg weakness, and it was taken to the ER. In the ER, thankfully, they were able to work him up and admit him, where he had imaging of the brain and spinal cord. So MRI of the brain, cervical, and thoracic spine showed multiple non-enhancing lesions. The neuro exam at that time, according to the notes that I saw, showed impaired gait, so he had some walking difficulties, spasticity, and cerebellar signs, so ataxia or incoordination. At that moment, even though he had non-enhancing lesions, he was given 3 days of IV Solu-Medrol, and he did report some improvement in his right leg weakness. The initial consult note by the neurologist, the attending neurologist there, showed that he had some fatigue with right lower extremity weakness, could not walk long distances, it was noted, and occasional imbalance. So just keeping that in mind as we go through the lecture, okay? So just a high-level overview. I know you guys are all very well familiarized with this, but MS is a chronic, progressive neurological disease that lasts a lifetime. There is no cure. That's a very common question that patients will ask you. Most commonly diagnosed during young to middle adulthood. The more common age for MS diagnosis is between 20 to 40, up to 50 years of age, although now, and you'll hear that, you probably heard that in prior lectures, we're getting a cohort of patients that are a little bit older than 50 being newly diagnosed with MS, so we have to keep MS on the radar at any spectrum of the age. Nearly 1 million people are diagnosed with MS. That's a very different statistic than what I used to give many years ago. I used to say nearly 500,000 people were diagnosed with MS in the United States, and thankfully they were able to update the epidemiological statistics and have a more accurate representation. So we're up to nearly 1 million people in the United States living with MS. Men are often less diagnosed than women. We all know that the ratio for MS in women to men are 3 to 1 to, some papers actually say 4 to 1. So for every 4 women diagnosed with MS, 1 man is diagnosed with MS. So it's drastically lower in MS. That disparity exists at almost like a tenfold in a way in NMOSD, where there's a bigger ratio. From every 9 women diagnosed with NMOSD, 1 man is diagnosed with NMO. For every 9 women diagnosed with NMOSD, 1 man is diagnosed with MS, is what I mean to say. So keeping those things in mind will help with the differential when patients come in, and making sure that we have an accurate diagnosis. So there are gender differences from onset and the clinical course. When we say clinical course, we mean the duration of their disease. Men are usually diagnosed a little bit later in age, so we typically see that in this case, this case that I presented to you, he's 23, but oftentimes we'll see that the men are a little bit older, closer to 30 years of age, between the ages of 30 and 40, which is pretty similar to NMOSD, where we see that difference as well. When we think of MS, we think young adult, prime of their life, graduated college, has a new job, bought a house, maybe having kids. And when we think of NMOSD, we think a little bit older, but men kind of fall in between that range. So keeping that in mind will help narrow down the diagnosis and help make sure that you have that in mind as far as the treatment considerations for future. Men will often experience more memory issues, and they will often experience more spinal cord involvement. So when we say spinal cord involvement, we're referring to lesions in the cervical or thoracic spine. And unfortunately, due to that, they will experience more motor symptoms. As you saw by the case that I demonstrated, I saw him maybe a month or two ago, and he unfortunately wasn't doing very well, but it depicts the reasons why preventative or early aggressive treatment in some cases may be beneficial for some patients, and we'll talk more about that later. I know that there's a lot of controversy between escalation and early aggressive treatment or highly effective treatment, but just keep those things in mind. It's not going to be a one-stop shop for all, but those are some considerations that you should take. And as nurses and as healthcare providers, we should all advocate. So if you are not necessarily prescribing the medicine, it does not mean that you're not making an assessment of the patient. You are interacting with the patient at all levels, sometimes more often than the clinician at that point. And so you are the advocate for that person. If you see that things are not going according to plan or what that patient is wanting to get out of the treatment, you should bring it up to the provider and you should bring it up to the patient and just ask those probing questions. Men are at higher risk of having more progressive onset, meaning that from the beginning to the end, unfortunately to the end, they may not necessarily be having relapse, they'll just gradually get worse with time. They tend to have lower relapse rates. Women actually have 20% more inflammatory activity than men do. So women are highly active in comparison to the men at this point, from some of the studies that have been published. Men are more likely to have a disability progression in the relapsing course. When we say that is when we have someone diagnosed with relapsing multiple sclerosis, they may end up a little bit higher on that EDSS. EDSS is the Estimated Disability Status Scale. And a 6.0 means that they need a walking assistance device, so they need a cane. And so men tend to be closer to that middle range from 0 to 10 than women. And so we have to keep that in mind as far as the treatment considerations are concerned as well. Survival rates are pretty similar across both genders. It's not a common question I get, but I have gotten that question before. Where like, do I have a lower life expectancy because I have MS? And there was a paper, I don't remember what year it was published, but when that patient asked me, I was like, I do not know, but let me look into that for you. And I did find the evidence that showed that perhaps on average, maybe 6 to 7 years of a difference from the general population. So there is, but there was no significant difference between gender to date. So back to the case. So this is the neurological exam. I'm just going to highlight it really quickly for you. In 2017, we're in 2024. I still see him now, okay? So I'm going to give you the updated version later. But loss of smooth visual pursuit, nystagmus, so the jerky movement of the eye on the right lateral gaze. Visual acuity is 20/20, so normal in both eyes. Motor strength appeared normal throughout in 2017. Increased tone in both lower extremities, kind of given into the spasticity. Brisk reflexes, so it was very jerky and very quick when you touched the tendons. A few beats of clonus, so some shaking in the left ankle. Plantar responses were elevated, which is a sign of CNS involvement. Sensory exam for light touch pinprick vibration were normal in all extremities. And he has some incoordination with touching his finger to his nose, so he had some mild dysmetria on the right. Fast finger movements were normal. Walking, so the gait was intact. It was grossly normal with some unsteadiness at that point. And when he closed his eyes and put his arms forward for Romberg, he had a mild sway noted at that time. So we're talking about MRI characteristics. We know the exam. We're going to look at the imaging. In relapsing MS and in SPMS, secondary progressive MS, men have fewer enhancing lesions. Again, we talked about that increase of 20% in women. There's a greater number of chronic active lesions seen in men. And last year, and perhaps in this year's talks, you probably heard the phrases or the term smoldering MS, chronic active inflammation that may not be captured on MRI, slowly expanding lesions. Those are all things that we are taking into consideration and perhaps that are contributing to this disease, and in particular to men living with MS. More of the T2 lesions will develop into T1 hypointensities or black holes. So on the radiology report, you might often see the term T1, T2. What is the main difference? The T1 means that there is complete axonal loss. So there's tremendous injury or devastating injury to that area. And the way that you see it is through a black hole. That's why they refer to it as a black hole, or T1 hypointensity. So when you look at this view here on the T1 sequence, you'll see that the spots are pretty much in the same location oftentimes as the T2 flares signal, but not always will you see a T1 hypointense lesion. So some of the lesions may convert and may unfortunately continue to deteriorate and cause this injury and result in this black hole. And that means perhaps that there's more chronicity to the disease. Unfortunately, it's not a newer disease for that particular patient. Overall, men have less inflammatory activity, but more devastating lesions, as I just explained. And men tend to have, or may have, let's say may, have higher rates of brain atrophy. So in general, for all of us, we will lose some brain volume as we age. That is normal. In MS, it's much faster. And it seems to be that men will experience this shrinkage of the brain a little bit quicker than their women counterparts, even though it's more often diagnosed in women. And this is not a real, probably the statistic could be more accurate or a little bit higher if we had software in all the MRI facilities, but unfortunately it doesn't exist in every facility. Not every facility will check for atrophy. So a lot of the times you're playing games with your own computer trying to see if you notice any of these changes to correlate with some of the symptoms that the patient may be experiencing. But if you do have the opportunity to order or advocate for your patient and say like they're having more cognitive issues, perhaps more issues with walking, you might want to remind the neurologist or the APP, whoever you're working with, to put that in the order to check for brain atrophy if possible. So this is the 2017 MRI. Just to highlight really quick the structure here, the corpus callosum, that you see the white matter changes happening around here. I know that the pointer doesn't really help, but maybe the mouse will if I move it. And you see here the same structure, pretty similar, the periventricular area, where you see the white lesions, the white spots coming out like little fingers. Those are often referred to as Dawson's fingers, which is what we look for on the MRI, very characteristic for multiple sclerosis. You don't see this in other conditions, and you definitely often don't see this in NMO, so that's a big differentiator. And some of the lesions here, and I just wanted to point out the spinal cord lesion. So this is C2, C3, C4. So this lesion is between C3 and C4, where you see on the proton density, because when I looked at the images, this one stood out better, perhaps for the presentation, so I picked this picture. The proton density sequence showed this hyperintense lesion in this area, which can be contributing to some of the symptoms that he is experiencing. And I know it's very hard to see because it's a small picture, but the thoracic cord here, you have little spots at different levels. And it's very hard to see because it's a very small area, which is why we really rely on the radiologist to help us. Once the radiologist does the interpretation and they give you the impression, you can kind of look over and then reference the lesions and make sure that they either exist or they don't exist, depending on the report. But those lesions there in the spinal cord contribute to a lot of the physical symptoms that the patients may experience, including bladder and bowel dysfunction. And there's different sequences for those that are interested in MRI. There's the STIR image, which is often useful in the spinal cord, especially in the cervical spine. PD sometimes can help with the artifact that we may experience when we're looking at T2 flare sequence. When the CSF is bright, it may interfere with the way that we see the lesions. But in the brain, we often look at the flare sequences more often because it helps to bring out the patchy areas that are hyperintense or that are brighter. And help differentiate what is structural, perhaps, versus what is demyelinating or lesion. The contrast may or may not be useful and may not always be ordered for every patient at every visit. So more and more we're moving away probably from doing contrasted MRI in patients that have remained stable for various reasons, including the unknown of the gadolinium residual being left over in the vessels and what the long-term consequences of that might be. But also that there is, thankfully, these highly effective therapies that really help maintain a quiet environment in the brain and the spinal cord, and therefore the contrast at that point may not be as beneficial. So you're kind of weighing your pros and cons there. And it's more costly, obviously, because you're going to do 2 MRIs, you're going to spend more time in the machine. Those are all things to consider. So men are less likely to seek care. They have been often, not always, often raised to be tough and stoic. And so perhaps them looking for help might make them feel more vulnerable, and that's not a feeling that we are familiar with. I say they, but I am a man, that we are familiar with, and we don't want to be deemed or seemed weak or dependent on anyone. We are the person that you come to solve the problems. So we're less likely to complain about any symptom, myself included. So you want to consider asking open-ended questions on general consensus, physical, cognitive complaints when you're seeing the person. Just ask how they're doing. See if anything has changed from their usual habits. Have their activities of daily living changed? Has their work performance changed? That can give you an indication. Maybe someone told you, one of my patients have said, I was demoted from my position. The demotion related to the cognitive impairment and the way that he was working. And that gives you an idea as to perhaps where you can help intervene and perhaps make an improvement for that patient's quality of life, or consider switching treatments depending on what they're on. So these are all very important questions, and I really can't tell you how important everyone's role is in the clinic when providing care. When a clinician is seeing a patient, we may not necessarily always have the full time to ask these important questions, but they might just tell you that when they're talking to you casually. Like, oh, I lost my job 3 months ago, and I may not even know that when they come to see me. I still see the insurance on the file. We're talking about meds. They're like, yes, renew all the meds, and they don't even tell me that they had a change in employment status. So it's important that you guys share that we all share that information with each other. And even myself, as a nurse practitioner, I collaborate with the physicians in the state of Florida. That is the rule and the regulation. So when I see things changing, I let them know as well, so that way we're both on the same page in case the patient calls after the hours or I'm not available to help answer their calls. So less likely to report symptoms such as sensory symptoms like tingling, numbness, physical complaints, cognitive difficulties, mood changes, and sometimes sexual function. I remember the first time I met this one patient who had seen several neurologists in my group, and I said, well, how's intimacy for you? Has anything changed? And he literally, I had a window on that day in that room, and he just looked out the window and would not look at me. He was shy, perhaps embarrassed, and didn't want to talk about it. So I said, we have help. We have a whole men's urology health clinic that can help provide an assessment, evaluation, and even treatment if it deems requirement. And he just would not talk. So then I said, the next time I want your wife to be here. And then she spilled the beans on everything. So it's important sometimes to include other members of the family or their partners in the conversation to kind of give you some insight. And perhaps that day it wasn't a priority for him, but then the next time it was a priority for his wife. And because, it doesn't always just affect the person, it may affect those around you, including mood, the way that you interact with others. So mental health, another hot topic that we probably don't get to discuss a lot in clinic, or that they might be less likely to want to talk about. There are higher rates, as Sarah mentioned in her presentation, there are higher rates of depression and MS in general, but more often in men. They probably don't want to talk about it. They keep it to themselves. They internalize it in a different way. Perhaps they want to figure out how to solve their own feelings at that point. But a lot of the times they can use a little bit of help, whether it be from talk therapy or meds. And so you want to talk to them about their options and see what's available for them. And with the expandment of telemedicine, virtual care has taken a skyrocket there in psychiatry. I advocate strongly for it. I always refer to them. And even when they don't tell me that they have depressive or anxiety, or they're like, oh no, I'm not depressed, I'm not anxious. I'm like, okay, well, you have maybe some symptoms that may resemble those things. So why don't you try to nip it in the bud now and talk to someone and then give them references. So psychologytoday.com is a very common portal that I recommend, so that they can look up providers with their insurances and that They can see who gives in-person versus virtual care. And they can do it from the comfort of their car. I've seen people in their car crying because they don't want to be in their house when they talk to me, even though I'm not a psychiatrist, but they just want to vent. And so they find places, it's very convenient for them to do so. So a large advocate for it. Men with MS are more likely than women to report suicidal thoughts when they are depressed. They may actually be more inclined to participate in risky behaviors, including substance abuse. Unfortunately, I have had the experience, and someone that lives very far away from my center where I cannot bring him in every time I have a concern, particularly with alcohol abuse, as a way to cope with the issues. He's legally blind from the MS. Thankfully, physically, otherwise, he is pretty stable, but it's just been a lot of life changes, and he's dealing with that ongoing, unfortunately, and I've tried to get him into rehab programs. I've called them myself. I put the referrals, but it's not that easy, especially in remote and rural areas. So just keeping those things in mind to ask those questions, and I have his father involved a lot because he's very minimalist, so he'll say, oh, no, and then the father's like, no, I found the receipts in the trash can. And so, like, you kind of get help from the family members is very important. And one thing that has been kind of off and on is the way that men cope with these changes and cope with the stress of having a diagnosis of multiple sclerosis. So there are a lot of different studies that show that men may actually not cope well with the diagnosis, and then there are others that show that they do cope well. And so I actually found this publication by Amy Sullivan, who's very well known in the world of MS and psychology, and it actually may vary depending on how the man was brought up. And so if they were brought up with repressing their feelings, then yes, they may not likely seek care. But if they were brought up with a re-encouragement or reprisal of their feelings, like, okay, how are you feeling today? Or in that manner, or like a heterosexual type of personality, they're more likely to receive care. So it just depends on the individual sitting in front of you. Get to know the person, get to know the patient, and see how you can help them. So talking about sex, as I told you, that guy that looked to the left, as soon as I said it, on my first date with him, because I told him, okay, we're on date 1. We'll talk about sex on date 2 or 3. And I got that joke from one of the neurologists that I work with. First dates, we don't talk about those things. But I felt that it was important that day since I was getting to know him. And he's had MS for a while. So questions are not often asked. And I think that a lot of the times it's because we feel uncomfortable. So we want to ask the question, but we don't know how to necessarily give them the answers that they need sometimes. Like, okay, well, you have ED, so let's talk about it. Maybe you don't have all the resources in the clinic at that time. Maybe you weren't able to do a quick literature search prior to the visit. I think that Tamika hit the nail on the head early on, talking about preclinic visits. If she tells me ahead of time that the patient has issues with ED, it gives me the opportunity to do what they all do, what she and Sarah and all of you guys do, is comb through the chart, look at the review, look at the meds. Maybe there's a med contributing to the ED. Maybe there are some abnormal labs. Maybe there's something else that might be contributing, and I can, talk to the person about it. But when it comes to screening and then evaluating and then treating all in one visit, it's not that simple. So just making sure that you talk about it and screen, and if you don't have the resources or the time, totally fine, refer. Know who to refer to. And don't just say, see the urologist. Really try to dig in and look who is the men's health specialist in that area, perhaps. There's now women's health specialists. There's men's health specialists. There's sexual dysfunction specialists. So I have 2 urologists. I have a urogynecologist. I have a men's health specialist. I know who they all are. I know where they're all located, or at least their names. And I put those on the referrals, and I tell the person, look these people up and get the appointment with them particularly. Don't get an appointment with just any urologist, because that might be dismissed. So we know that androgen levels decrease as we age and with chronic conditions, and especially seen in MS. So it may lead to diminished desire or arousal, ED, as we talked about, erectile dysfunction, fatigue, depression, loss of muscle mass, anemia, and increased visceral fat, and obesity, which, to Sarah's point, can lead to a long-term complications. So trying to see where all these changes are occurring is very helpful. So an estimated pool prevalence of sexual dysfunction in men was noted to be at 63%, and this was getting literature and combing through all the literature and then pulling all those statistical data that they had available, and they came up with 63% of men may experience sexual dysfunction at some point, or long term. They may have difficulties with achieving or maintaining an erection, maybe contributing from a psychological perspective, or maybe a physiological perspective, or both. Could be both. They didn't have a good experience the first time with that person, and they're less likely to have a second experience with the person because they feel like they may not be able to perform to the way that they wanted to perform to the standards. Men with MS are less likely to participate if if they've had experience before with sexual dysfunction. I've had patients tell me like I have an erection, but it's not as powerful as it used to be, or midway I could not orgasm, or I couldn't get it up. And so those are all things that we commonly hear. And it's very important not just to dismiss it. Even if it's psychological, it doesn't matter. Even if you think that the mood can be contributing, acknowledge the problem and help them. So either refer to psychology and urology if you believe it's a psychological perspective, perhaps. Maybe they're amping themselves up and they don't necessarily perform to their standards, but they're able to perform, or maybe it's organic. And so making sure that we acknowledge that. The role of testosterone in MS is still very unclear. Testosterone is a natural anti-inflammatory hormone that exerts suppressive effects on both the humoral and cellular immune responses. There is a high prevalence of hypogonadism, which is low T or low testosterone, reportedly in up to 40% of patients with MS in some studies, which is different than sexual dysfunction. It doesn't necessarily correlate. You don't necessarily have sexual dysfunction because you have low testosterone. Sexual dysfunction may be related to spinal cord involvement from the lesions in MS. So keeping those things in mind are extremely helpful, which is why I'm not ordering testosterone levels in my office. I'm referring to the urologist. But knowing your resources is important. So low testosterone levels have been reported or associated with a greater number of enhancing lesions, greater cognitive decline, an enhanced risk of developing MS, and an increased risk of disability. However, high levels of testosterone, and by high, we typically mean high or normal levels, right, not deficient, may have neuroprotective effects and may be protective in the development of MS. So every 10 years, another guy or another man is dealing with ED, perhaps low T, and that gets higher and higher as we age. So if they don't have MS at that point, they might be at a higher risk of developing MS if not treated on time. And it doesn't mean that every patient needs to be screened for low testosterone. You ask the questions and you assess the person and make sure that you have a rationale for ordering these tests, or work with their primary care provider if needed. Men report to experience lower quality of life and achievement of goals. They want to do more oftentimes and they can't for various reasons. Sometimes they feel like they've lost their independence because of their physical disability or ongoing symptoms that may result in that they're no longer the provider of the household, that they're no longer the protector. I mean, I had one person who got married, though him and his wife, at the time his girlfriend knew each other, were diagnosed with MS. I met them at that point. And unfortunately, throughout the years, he's progressed, the same person that lost his position, and they had a baby, and then they got divorced. And unfortunately, he couldn't run with his child. That was his main complaint in all the visits. I can't keep up with my girl. She's 2, she's running around. She's 3, she's running around. She's 4, she's running around. I can't keep up, Jeffrey. So it's very hard sometimes to see how we can help. So it's important that if we may not necessarily have an answer at that point, that we give a listening ear and we help with the talking. They often don't have the same level of social support. So his wife and him, they divorced. So now he's living alone. And like that, I have a few others actually, who were high level functioning. One was an executive on an airline, lost his job due to cognition, divorced, now living in an apartment on his own after he was living in a large home in a very high affluent neighborhood. Things happen, things change. So making sure that they have the level of support. And he actually said, "Can I come see you every month?" And I was like, "I would love to talk to you every month, but I don't think it would be a good use of your resources. So if you need me, you call me, but I'll see you a little bit more frequently, just not monthly." So sometimes they want to discuss these things and they just don't have someone to talk to. Making sure that they have access to a social support program, perhaps the National MS Society or MS Foundation or MSAA. They may know who around the area may be holding these sessions, and they may participate. Loss of employment before retirement or disability may actually negatively affect their relationship with their partner or spouse. I know for the Hispanic culture, I can speak for myself, that we are considered head of household. We make the money, we make sure everything is running the way that it should. And if I were to lose my position at work, or not be able to function or not be able to work, that would put a detriment in my goals, because that's my goal as a Hispanic man, is to make sure that my family is provided for. So that is actually negatively affecting, and that can affect my mood. It can affect the way that my wife perceives me. It can affect the way that your partner, if you don't have a wife, your partner might perceive you, and that doesn't necessarily lead up to a very positive relationship and lead up to divorce and other things. So, making sure that we talk to them and we refer them on a timely basis if possible, cognitive rehab if possible, neuropsychology if possible, those are all things that are very helpful. Fatigue and physical disabilities may impact their experience as fathers. The patient told me he couldn't run with his daughter. That's all he wanted to do, was run around with her. I mean, I get it. I have a kid, so I want to run around with her too. So that affected me, and I'll tell you about the case later. That also affected me, but things happen, and for men, sometimes it's viewed differently, or we take it differently, or we express it differently, and we feel it differently. So just getting to know your person that's sitting in front of you. So some tips for you. Perform a detailed review of symptoms and encourage the patient to report their symptoms earlier rather than later. And even if they don't want to talk that time about ED, I just said, hey, whenever you're ready, I'm here. Or I can send you to the urologist, whichever the two you like, and we could talk about it. Screen for depression, anxiety, and suicidal thoughts at every visit. Tamika has a great point. If you can do the pre-clinic visit that she mentioned in her presentation, this is a great time to do those brief screenings. And if there's a question, finish the screening with the questionnaire up front at the PHQ-9 in person if you need to, and identify depressive symptoms or anxiety. Screen for sexual dysfunction and refer to the specialist as needed. Testosterone supplementation may improve libido, energy, muscle strength. There might be some lab abnormalities associated with supplementation. However, that's up to you and the urologist to work out as to what screenings are required, and just making sure that whoever you're speaking to about supplementation, that you also mention fertility. That's very important in men, because they may not be thinking about that. They're thinking about the woman getting pregnant. But when you're supplementing testosterone, that may affect the way that you may be able to have a child in the future, or even currently if that's what you're planning for. So making sure, just like we talk to women, what are your pregnancy plans? Do you have any family plans at this moment? Do you want to wait 3 years, 2 years? And that's how we help make a decision on treatment. Talk to the gentleman as well. Have their spouse, partner, family member, his wife spilled the beans. So if it wasn't for her, I wouldn't even know half the stuff that I knew at the next visit. So if you have the opportunity to invite someone, even by phone, I did that one by phone. He called her on FaceTime, and I put her in front of my computer, and I was just typing. We were talking, and we got it done. But utilize the telemedicine tools that we've learned thus far to help. Encourage positive behaviors. So I talked about exercise. I think that everyone brought up a good point with exercise. I do the same. I tell them, hey, you're not exercising right now, so why don't we do 15 minutes? So by the next time you come in, I'm writing it on your note. That's what I tell them. I'm writing it in your note that you promised me that you will do 15 minutes once or twice a week. And if you don't do it, I'm going to know the next time. So that's how we kind of joke around about it, but I encourage them to do a few minutes of exercise, even if it's not a full 30, which is what's recommended. Modification of diet. They often ask that. There is no FDA-approved diet for MS, but Mediterranean actually helps with MS, with comorbidities, and fatigue. So that's one of probably the most studied diet available. I have people that have done all diets, including the Swank and Terry Walsh. Mixed results. It's not that I had a large population, so I can't really speak to each of them, but mixed results. They're smoking, quit smoking, which can lead to further progression of their disease. Aside from the cough, lung cancer, and other things that can happen because you're a smoker. And then begin disease-modifying therapy as soon as possible, and talk about the treatment, the benefits of starting early. Before, when I first started, I remember those patients that would come in with like the approach of holistic care. I want to take vitamins, I want to do this, I want to do that, I want treatment, but we know now, we've heard throughout this week, treat MS, deliver MS, the benefits of starting treatment early, whether they go on a highly effective therapy or standard platform therapy, it doesn't matter. It's up to the patient and the providers. But starting treatment early, not waiting to see if we can tame the horse or, put the water on the fire and calm everything down as quickly as freeze the condition is usually what I tell people. Like, we want to freeze it where it is. We want to keep you stable. So let's work on this together. And if it doesn't work, you're not married to it. You can always change later. But I don't know to change unless you tell me to change. So, working together on that. So let's go back to this case study. Just to give you a quick rundown, in 2017, when he was diagnosed with MS, officially after 2 years of symptoms, he was started on natalizumab. Transition providers who noted in 2021, so about, my math is off, 4 years more or less, transition providers, and they said, okay, well, he noted the right leg weakness and other symptoms that continued to progress even on natalizumab. They switched him to ocrelizumab that same year. And unfortunately, in 2022, just like many of us here probably and many of them, he developed COVID infection, which he felt set him back tremendously. He felt that the infection was like the worst thing that could have happened to him as far as his improvement and stability in regards to his MS, and it just set him back a lot. In 2023, last year, I want to kind of give you like a summary of an update. So 2023 of last year, he continued Ocrevus. I had recommended an AFO for his right leg weakness and the right foot drop, versus a sleeve, which you guys probably saw. I've been recommending for some patients the Sionic sleeve, which could be beneficial as well. Talked about symptomatic treatment and physical therapy. The neuro exam showed was remarkable for dysmetria on the right more than left at this point, so we're talking about 5 years later. Dysautokinesia, so he was having problems with coordination with the right upper extremity, spasticity in both lower extremities, and now he had right hemi-body weakness. So it wasn't just the leg, it was also the arm as well, and impaired gait related to right leg weakness and spasticity. So just to give you a summary, he's a new dad in 2024, continues Ocrevus, and he noticed some improvement with PT. Neuro exam is grossly stable. When I say grossly stable, I'm comparing it to the prior one, not the one that he started with. But grossly stable compared to the last one. He has a circumduction gait, so he's swinging the right leg over due to the weakness in the foot drop. I recommended, again, another course of PT, OT. I emphasized, again, the importance of an AFO or Bioness, Sionic sleeve, whatever he can get. A trial oral medicine because he was complaining about fatigue. And sadly, and a cane. I actually recommended a cane, even though he's very young. He's in his 30s. I recommended a cane to prevent falls because one of his complaints was, I can't hold my daughter. And she was a newborn. Sorry about that. It happened that day too. So we're talking about the MRIs here in 2023, where it showed the similar lesions, so they hadn't changed much. And then on the right, you'll see the hypointensity as well, where you see the black holes. Again, talking about chronicity of the disease. And then I want to show you, which we don't talk about often because it's very hard to see, but I want you to take a look at this level of the spinal cord, the cervical spine here. 2023 compared to 2017. If you look at the 2017 image, I want you to look and think of your finger when you look at the cord and look at the thickness. And then look at the 2023 MRI at the same level. Try to visualize it. You see atrophy. And that's very hard to tell on an MRI. And the same thing happens with our brain. So the same thing that happens with our brain happens with our spinal cord. Probably less often with the spinal cord because we have little real estate. And it's very hard to tell. Again, we don't have that software. But it's pretty evident here. And that was what I saw that day when he was complaining about that. I can validate that he has progressed. I can validate that. And that was on natalizumab. And that was on Ocrevus. So this just tells you that even sometimes starting on a highly effective treatment early on is still very difficult to tame the disease. And not everyone is going to have the best outcomes. But it's very important that we do our best to try. And that is a strong consideration for all patients. Okay? So that concludes my presentation. These are the references, and my disclosures were noted on the app if you need them. Any questions?
Here I go again. I'm going to pop up just for a minute. You come on up over here too. I think that, some of the takeaways that you'll hear from all of our speakers is many times our patients come by themselves, and I think it's so important if they can bring a second set of ears with them. I've been a nurse forever. I get stressed when I go to see my primary care. I make myself a list, but if you've got something of great importance, or you're talking about change in disease or change in treatment, that second set of ears is so important. Not everyone has the luxury that they can break away from a job or whatever, but that is one thing. The second comment that I'll make very quickly is yesterday's session 3, Mona Bostic, who is a registered dietitian, nutritionist, was there. If you'll go to her slides, there are some great resources about dietary recommendations and using that individual in the area there. So I'm not going to ask anything else. I'm going to have others come on up here and ask questions, and we'll get the next set of slides up.
So I'm here from the PT perspective. I saw that during that time in 2021, there was a progressing leg weakness, but you did not right there that you did send to PT as compared to in 2023 when you actually did. Yesterday I was at the rehab conference, and we were looking is there anyone else here in other disciplines? And unfortunately, it's all PT in there, and so they said early referrals really a must, but they're preaching to the crowd who already knows it yesterday. So it's during that time, and there was also a slide in there that showed they did an AI simulation, and I don't know if you remember those beta seron, that there was a lapse of person that did not get the treatment and they didn't catch up. So they did that slide, and it showed that PT referral usually is not caught in the first 5 years. So it's after 5 years that patients getting symptoms, because everyone does want a quick fix. So as soon as you give steroids, some of them immediately gets better. So they don't think about it anymore. But getting that 5-year lapse, and they showed how the curves came out, but this wasn't a study, this is just a simulation. So it's the same as that beta serum. Those people that got the PT later was really low, and they didn't catch up on getting back most of their strength. So I just wondered if we had been referring earlier, would those people not be as weak, especially now that we know all of these markers that they are finding out that the NFL and the BDNF are really there or increased right after getting that aerobic treatment of 30 minutes.
Yeah, no, that's a great point. I didn't put it on there because when I did the timeline, he wasn't my patient then. I didn't have time to comb through all the things that happened that visit. But I agree. When someone has even the mildest change, whether it be the hand or the leg, I often refer to PT/OT, and some patients actually push back because I refer it almost every year. I said, just go once or twice. See what exercises are new, see what you can learn. They're like, but it's always the same thing. I said, so I understand, but if you can make it out once or twice, that's all I'm asking. Learn the exercises and do them at home. But I am a strong advocate for PT/OT in all aspects of their care. And when we have options for pelvic floor therapy as well, for women more than men, but I know that men can go to pelvic floor therapy, that I usually leave for the urologist to decide when it's appropriate that they go to pelvic floor. But yeah, I completely agree. Thank you for the comment.
Hi, everyone. I'm a man with MS, and I know this is our first day, but I move fast. So, in all seriousness, I have two statements. First of all, everything you said tonight really resonated with me, and I appreciate the presentation. Even though I'm not a physician, I loved seeing and hearing everything you said. Second of all, highly recommend y'all, highly encourage your male patients, go to the urologist. Tadalafil will make their quality of life so much better. And finally, if I can remember it, because I have MS, memory stinks. One other thing, planning early is always better than planning late. But if you don't plan early, start wherever you are. I don't know where you feel about this or what your medical licenses will allow, but I would say just recommend to your patients go to financial planning. I have lost my job. Luckily, I have a finance undergrad, so we saved copiously, much to our demise, because we weren't able to do vacations and stuff as much. But we are in good shape today because of all the planning we did early. So those are my statements. Thank you.
Oh, thank you. Thank you. It's a good point about financial evaluation and also living wills. Just get everything out of the way early so that way you don't have to think about it later. That's always going to be beneficial. But I want to thank everyone for their participation and for staying. And we hope that you enjoy the next few case studies.
So we're going to invite the faculty up, and I'm going to turn this over to our faculty for the case studies. Before I forget, please do the evaluations in case you have to leave early. This is how we do our planning for next year. Be kind, be unkind, be truthful. You know, that's what, it's not going to hurt our feelings if things worked or didn't work. The other thing that motivates me is food, and there is going to be a grab-and-go lunch available. I don't know at what time, but they say it will be here on the second floor, so you'll be able to watch for that. So thank you again all, and we'll let our faculty get started. So Jeffrey, you going to get us started?
Yep.
All right.
Well, we know that we're short on time, so we're just going to skip a few, okay? All right, so this is, we had 3 cases for you guys. We're going to skip 1. We're going to go to 2 for now. So this is a 44-year-old white male diagnosed with secondary progressive MS. He was diagnosed with MS in 2007. This is actually, I think, Sarah's case, right? With symptoms, MRIs, and he had a lumbar puncture to verify or support the diagnosis. He was previously on interferon beta-1A, then switched to teriflunomide, and then it seems that he stopped treatment altogether. Later, he was started on ocrelizumab and was on it for about 2 years, and the last dose was greater than a year. So it seems like he has a habit of not remaining on treatment. He moved from Colorado to Texas, where to Colorado from Texas, where he met Sarah. Current MS symptoms include hand numbness, tingling all over, fatigue that varies with mood, bladder, so some incontinence and constipation with rare bowel incontinence, so neurogenic bowel as well. Occasional left blurry vision or left eye blurry vision. Spasticity in both legs. Prior to 2018, he was using a rollator, so the ones with the wheels, the walker, to ambulate. In 2018, unfortunately, he was in a motor vehicle accident and fractured his leg, and unfortunately had to use a wheelchair. Living at a care facility after the motor vehicle accident in Texas, his wounds, due to his wounds and his legs and lymphedema. Unfortunately, he developed sepsis, bone infection, and gangrene, causing a amputation in 2023 of the lower extremity. And currently, when Sarah saw the patient, he had his wounds back to the back of his legs that were weeping. He was working with physical therapy on lymphedema therapy and wrapping. He could transfer on his own to and from the manual wheelchair, but he needed a motorized wheelchair to get around. Social history includes that he's a homosexual man living with his sister. So he doesn't have a partner, he has a sister that he lives with, and they're working on placement. They're working with him to see if they can get him in an assisted living facility. So I'm gonna pass it on to Sarah, to talk about comorbidities.
Thank you. So his comorbidities are, he's got anxiety, depression. He has a history of PE and DVT, so he was on a blood thinner. He's had a history of bariatric surgery, so paying attention to his nutritional intake and maybe some of his vitamins is important to keep an eye on. He's got that left below the knee amputation from the wounds and sepsis that he had. He is wheelchair bound. He also struggles with migraines, and he has that lymphedema that we mentioned with weeping wounds, but is working with physical therapy. So now we're going to go back a little ways. Well, Tamika's going to tell us about the interdisciplinary team, and then we will come back to that case and talk about his interdisciplinary needs.
Okay, so we're gonna get some crowd participation. I know we're all ready to go, get ready to go on our planes, but we're gonna talk about the interdisciplinary team and how important it is to get the whole team involved. When we have a whole team involved, it is just a group of professionals from different disciplines who work together to provide the best care for the patient or a group of patients. So the team of experts, this is the list of who can be included in an interdisciplinary team. It's not exhaustive. There could be other people that's on the interdisciplinary team, but I have the pleasure with working with an interdisciplinary team, and we have all of these members on our team, and to see the collaborative works that we are able to do as a team is amazing. We get to discuss the patients from the beginning, from admission all the way to discharge. You know, we can have everybody in the same room, and not everybody has that opportunity to be able to have physical therapy in the room, occupational therapy in the room, a neuropsychologist in the room, and we're discussing these patients, and everybody's information is so valuable that to be able to have that for our patients is just amazing, and to see the team work together and not in silos is amazing. So to see that in action, if you get the opportunity, it's just amazing, and the outcomes for our patients are amazing as well. So physiatrists, attending physicians, physical therapists, some of them do driver's rehab. We have our occupational therapists, they do wheelchair assessments, our nutritionists, social work, psychologists, our neuropsychologists, wound care specialists, our nurses, we have a clinical pharmacist, our virtual care team, right? And we have extended care services all working together for the good of the patients. So this is a model that we use. One of the key components to an interdisciplinary team is the partnership of the team with the families and the caregivers, right? So at the VA system of care, we use a whole health principle, and it's thinking outside the box. And here you see the triangle of healthy caregiving. The triangle of healthy caregiving is a patient-centered intervention that incorporates the veterans and their caregivers, but can be applicable within the patient and their caregivers. And it extends into the homes by using real-time clinical video telehealth, which is that where you can see the patient inside and out, in their home. And this team consists of everything. If you can see everybody that's around the circle, so you have for us is the veterans at the top, and then you have the healthcare providers, the caregivers, and then in the middle is that interdisciplinary team that is able to connect and work with the patient and the caregivers to accomplish their goals. What we like about the whole health model is it's not about, we don't ask the patient what's the matter with you. We ask them what matters to you. And when you have an interdisciplinary team, this is what that team does. This is how we partner with the patient and their caregiver. I say veteran a lot, but patient and their caregivers to accomplish this goal with the team as their partner, so we can help them accomplish whatever goal that is they're trying to accomplish. I wanted to talk about the difference between an interdisciplinary team and a multidisciplinary team. They are not the same, right? They're different. So an interdisciplinary team, we work collaboratively together. But in multidisciplinary team, they don't, not so collaborative. So you can have a patient that needs a prosthesis, and they'll go to the prosthetic department and get their brace and go on about their business, but then they'll come see the physical therapist later on, and it's like, well, who ordered this? You know, this might not have been, you know, appropriate for that patient at the time. So the multidisciplinary teams, although they have different disciplines that's working on the team, they don't work collaboratively, and they may not discuss the patients together, so that the physiatrist doesn't know what's going on in physical therapy, or occupational therapy doesn't know what's going on with physical therapy. You know, they give them a walker where they need a wheelchair, and there's no connection. It's just everybody working in silo. So that's a difference between an interdisciplinary and a multidisciplinary team, and we want to work in an interdisciplinary team that we can able, you know, to discuss the patients, and we're connected to them. So some discharge resources that we actually have, you know, we can, on this interdisciplinary team, so you have home care, you have skilled and non-skilled services, adult daycare, virtual care technologies, caregiver support programs, just regular support groups, and then you have skilled nursing needs here. And anybody on the interdisciplinary team, if you know the veteran, if you know the patient and you're involved in the care from the admission to discharge, you can make a referral to any one of these, or you can discuss with your colleagues, you know, do you think that the patient would benefit from this? Well, you know, what are your thoughts about that? Do you think the patient needs to see outpatient PT or, you know, occupational therapy or what have you? And that's the benefits of working with an interdisciplinary team. So now that you guys know who's on an interdisciplinary team, and I'm sure you know occupational, what their roles are, we can discuss the other case to see, to get you guys involved to see what type of support we can give the first case that Jeffrey presented.
We already talked about it.
Okay.
So I think-
All right, so this 44-year-old male that Jeffrey presented, who do you think should be on his team? You know, he's a 44-year-old male. He lives with his sister. He has wounds. I think she said he was able to transfer, you know, independently. He's a part of the LGBTQ plus community. So who do you think should be on his team?
I would say, she sent me anyway. 44-year-old white male. I've been obviously so many people, but I'm going to start off with sexuality is a huge piece and functioning for young and adults, males and females. And so having the urologist be involved early on to see what matters most to him and how, you know, because that's a big fear I find in a lot of patients, and it's a part of their functioning that sometimes gets missed or ignored, right? Because we're so busy on the disease progression, and we're so busy with all of these other things that intimacy, right, really matters, and that sometimes gets missed. I'll let my other colleague continue, but I just gave you one. What did you say? I said I just gave one, but continue. Wound care is definitely a home team deal with nutrition. They didn't have nutrition because there's either wound, either breakdown, there's a lot of factors like that.
Social worker, psychology, wound care, Absolutely, okay. Who else should we have on this patient's team?
Just from the look of loss of care multiple times for him, he's had bariatric surgery, which will affect his ability to absorb nutrients. So you may have someone managing the amputation based on a generic, someone with an amputation trying to ramp up proteins that his gut isn't going to manage. So you're going to create different problems. So I would want him to follow up with whatever team member you have at your place that does bariatric follow-up, and work with their nutritionist. I know that most of us in MS don't have our own personal but in the priority list, MS is definitely on there, but he's got to get those, death will come from those wounds or further amputation. So that's number one, and if, without the nutrition, they're not going to heal. So for a period of time, that, I feel like that has to be at the top of the list.
Absolutely.
I'm gonna also add, in addition to everything else, that since he's living with his sister, some support, caregiver support for his sister, so she understands.
Absolutely.
You know, the disease progression, right? Especially as we think about getting neurology or psychology involved, to do some cognitive testing, dealing with possible depression, and, you know, just making sure that the caregiver is not like you're just being lazy, or why aren't you doing more for yourself? This is such a caregiver burden. So that's something that's not always thought of, but in addition as well.
Absolutely. So see, these were some of the things that, everybody brought up. So physical therapy for the lymphedema, he may need a motorized wheelchair, occupational therapy, mental health, social work, to help with placement, right? Case management for other complex needs, support from the LGBTQ plus community, support for his sister, his caregiver, transportation. He's missed several appointments. And to add the nutrition piece up here as well. So again, complex interdisciplinary needs for a patient who has access to an interdisciplinary team. So more of the, and to have all of these people in the same room communicating about this this patient, the outcomes will definitely be great. Okay, so we're gonna have Sarah come back and talk about the social determinants of health.
I have to say, this patient was the most fabulously dressed patient I've ever seen in my office. He came in this like crushed velvet suit. It was amazing. He was very impressionable. I loved it. So I talked about earlier in my talk about the social determinants of health, and I think this is such a thing that is important in looking at these patients holistically. So again, what is their background, what is their education, what healthcare quality that they've had in the past, now, their neighborhood, social and community interest, and then economic stability. So I kind of evaluated him, and he has a history of a high school education, but he had amazing health literacy and has become, even though despite some gaps in his care, especially MS-wise, he's become an amazing advocate for himself. He came into that visit and he told me what he needed. He knew what referrals he wanted to do. He was already working on placement, and he'd already gotten his insurance set up because he was Medicaid from Texas to Colorado. So he was an amazing advocate for himself, which was really, really impressive to see. So again, that Medicaid had transferred over from Texas to Colorado. That was his health care and quality. The neighborhood, he had grown up in rural Texas in an area that did not have good support for his LGBTQ lifestyle. And moving to Colorado, we all have room to grow in that department, but he felt much more safe and secure and felt that he was going to have more resources and connections in the community that we're at in Colorado. Social community context, again, he's living with his sister for the moment, so that does give him some limitations, and obviously when and if he moves into a care facility, that is also going to have some limitations with that. But again, making sure that he's got transportation options to go and participate in events and have that community support that he needs within the LGBTQ plus. And then he has disability income, but it is fairly limited on his economic stability. Any questions on this particular case, or thoughts, or anything we missed? Jeffrey?
I think I was thinking as you were speaking about the comment on neurology, he has same-sex partner, right? What about PrEP? And now the new regimen, DoxyPEP. So we have to take the PrEP into consideration. I do remember I've had a few conversations about PrEP in my patient care visits to remind them, as far as prevention is concerned, if they're not monogamous, that they use preventative therapy. However, that may impact their DMT use, so have to keep that into consideration. So when they're on PrEP, it's a retroantiviral therapy. how does that impact the treatment that they're on? So just keeping those things in mind when we talk about patients, keeping an open mind is what I'm trying to refer to, the take-home messages. You know, we want to treat their MS, but we also know that because they have MS, it doesn't protect them from everything else, as Sarah very nicely mentioned earlier, including HIV and STI. So keeping that in mind is very important.
Absolutely, and I agree with Jeffrey completely on that. And, you know, clearly we wouldn't want any of our patients to get anything like HIV while they were on an immunosuppressive medication. So, so keeping that in mind, that's a great add-in. I appreciate that. Absolutely.
So I see that, you know, there was consideration for nursing home and long-term care. Was that for long-term care or short-term for the wounds, and why not try to keep them home with services? What was the thought behind that?
So this was his request. So he had been in a care facility before, and I feel like at this point, he felt like he had moved in with his sister, but I think her home was not necessarily set up for him and his wheelchair needs long-term. And so it was his request that he wanted to get into a care facility situation for long-term care. So I know. And unfortunately, in our community, we don't have as best resources we could get with that. But I'm hoping to get him in for a follow-up visit. He's missed the past two to kind of talk about what we can do to potentially, if that is available, for him to stay in the home or other options. But that's a great point. I really appreciate that. Any other thoughts on this case? Okay.
We have
So-
15, 20 minutes, so we can do one that's quick.
We can either
another
do one
case.
quick one, or do you guys have any complex cases? Yeah, absolutely. So after his first missed visit, so his ride transportation didn't show up. So we contacted him, and he got a second follow-up visit made. And then I knew he was on my schedule for that day, and I was looking forward to seeing him. And then he suddenly dropped off. And so I look back, and he had, or at least someone had logged into his account and had canceled his appointment. So that was literally like 2 days before I came to see MSC, but he is on my radar to get back in touch with as soon as I get back into the office to make sure that he gets rescheduled, because it is important with his intermittent visits. And I'm going to give him the option of doing telehealth as a follow-up appointment, if we can at least do that. Since I have had a chance to assess him recently in clinic, that at least we could have that conversation virtually.
Anyone have anything that they, no?
I do have a question, because Jeffrey did a wonderful presentation about men in MS, and
She was paid to say that because we work together.
no, but you did, and you're a very sensitive person, so patients open up with you. You have a lot of experience also with the transgender population in our practice, and that is very important. We need providers like you. And I want to ask any of you, have you ever encountered, how do you address a patient that complains of decrease in the libido or decrease in the sexual functioning due to MS or due to a medication? Because I do have patients that had stopped treatment because they believe the medication is contributing to that. How do you address that?
You go ahead.
Do you have any perspective to share? You want me to start first?
You go ahead.
So for my clinical practice, I generally do, as they both do, comb through the meds first to make sure that I spot any contributors. If I do spot any contributors, I might consider switching a med. For example, for the antidepressants, I might consider Effexor instead as one option if they don't have history of seizures. That could be one option. Or the other option would be adjusting their dose. So if they're on a higher dose, maybe reducing their dose, or vice versa. If they're depressed, then I might increase their dose to see if that would help with the fatigue or the sexual function. The other thing would be a panel of labs, just to make sure that all the labs are within healthy range, including ruling out anemia, thyroid dysfunction, and other things. If I feel like all of those things have been exhausted, and there's not much else I can contribute to that visit, then I would definitely, from the beginning, probably even refer to urology, because sometimes it takes time to get an appointment. And then I'll tell them, if you don't need it, just cancel it, but at least have it. And refer to our men's health. We have a men's health group, actually, and they do a very great job of evaluating and treating our patients. They actually use combo drugs for erectile dysfunction. They'll use a combination of 2 drugs, and they compound it. And for patients that have had one and it didn't work, and they tried another and it didn't work, they'll put them together, and they can take that almost every day. So it's a great option and resource that they have. They also do injections if needed, and they evaluate the patient in its whole. They also talk about fertility, and they will help with those issues if the patient is planning to have children in the future with a partner or via surrogate, that they will help preserve the sperm, so that way they can have the opportunity in the future to have children if they need testosterone for low T or other treatments. Does that help answer the question? You guys have anything else?
No, I don't have anything else to add to that. I think that was great resources.
I was curious, just an add-on, how do you approach your female patients?
Well, that's probably
Yeah, again, I think it's kind of a similar pathway. So I'll look at the med list to see if any of their medications might be contributing. I may talk to them about, is it dryness? Are you dehydrated? Is it stress because, you're taking care of the family? And is it fatigue? Is it depression, anxiety? What might be contributing? And then if I think I've kind of exhausted everything from the MS component, I may either send them back to their primary care or to OBGYN to see if they have any other options for that as well.
pain is important.
Yes,
an important
spasticity.
aspect. I've noticed that some people will say that they have low libido, but it's not really low libido. As you mentioned, it's dryness that may contribute to pain, and they might benefit from topical ointments, depending on the age, based on the evaluation, to help, because things change as we age. And for women, it may be the same. So that and a evaluation by a urogynecologist typically helps to make sure there are no structural changes that may be contributing to pain or a tilted pelvic floor. There's different things that may contribute to that. They might benefit from PT for pelvic floor therapy as well to help.
Absolutely, yeah.
I'm not a provider, so I don't prescribe, but one of the things that I have seen in the clinic is the issue with intimacy. So when you develop MS and then you're so focused on the disease and what else is going around, you forget that part, right? So is it really the MS? Is it depression? What is it? Could it be that there's a lack of intimacy because of the disease and you're not focused on it anymore, right? So getting back to the intimacy with your partner may supersede all those other symptoms that you're having, right? So we shouldn't forget about the intimacy between the partners, because that could,
Planning.
be an issue as well.
Planning, if all else fails, plan
Yeah.
a date. And
Yeah.
that date is where you are mentally prepared to do that. I had one patient who called his wife in front of me. It was like, can you tell her that we need to do it this many times in this many ways? I was like, only if you guys both agree.
I was gonna say, not necessarily with MS patients, but with MS patients with advanced MS and with thyroid patients, sometimes it's the spouse or the partner who's like, they're still interested in that, right? And they're like, yes, and so, just demystifying that and having, just making it matter of fact makes a difference. And patients are usually really happy, especially as a social worker, when I ask those questions, and I'm like, I'll let the physician know that talk to you, they're like, thank you, right? Because this is something that matters to them, but we're so busy, they're so complex, that there's so many things to cover in a session you don't bring it up, we'll talk about everything, everything else, right, spasms, so, yeah. And I think bringing it back to the caregiver as well, right, we can't have these conversations in isolation and not have the family member be also part of it in some way.
Absolutely. Absolutely.
Very good feedback from everyone in the audience.
Yes. Go ahead.
Just wanted to ask, how can I get my providers to even ask
About sex?
I have one of those.
I think that sometimes, oh, sorry.
I was trying to use the concept of when you're preparing your clinic or looking at the chart as well, they can look at questionnaires, like I think one of my questionnaires, like, for example, I had a case, young man came in, new diagnosed MS, and I was looking at my very young teen partner, asked questions, do they have a partner, or they actually have a partner? And there's pamphlets that from National MS Society that talks about partnership and sex problems as well. So you can bridge it that way, or just ask as your general question. Also says like, well, how many do you have any questions of sexuality? And because I did that, with veterans, they was better than I think the doctor saying, hey, refer to neurology, because we had no idea that patient had issues in that area.
Yeah, I agree. I was just gonna say that something very similar. If the provider is shy, for whatever
Right,
reason,
yeah.
and you're not shy, I think that you should just throw it in their face when they
She
come
said, "I'm
in.
not
So,
shy."
If there are nuggets that, I don't know if any other nurses in the room would feel like there's like 20 things you wish you had in your clinic, and you might feel excited about what you've learned this week and also terrified of how much you bring up is now going to be told for you to do it. That's one of them, and I made it plain to them that I don't think before it came that I think we need to mention it more. I'm not always in the room with the provider.
But prior to that, when
But-
you talk to the person, that could be something like Tamika said, the pre-planning, pre-visit plan, like when you have the 15 minutes to do the vitals, if you casually ask and you might be able to bring it up, say, let me let your provider know that you're ready. And that could be something like a preemptive, like, hey, they're doing okay, but they have some questions about sex, or they have
Absolutely.
some issues with intimacy. That
Without
might
even
be a
going
good way
into
to
too
bring it
much
up.
detail.
It's usually that our patient brings it up.
Yeah.
And by then, I feel like they've worried about it for a while.
Yeah.
And finally said it, and that, I feel failure, that they did.
Another thing I usually recommend with my MS patients because of memory is do the favor, you have to put next on that seat, have you come to the neurologist or PT. So you have a notebook handy, if not when you say you want to. Have stuff in the office, right? I said, I want you to write it down, the day of your appointment, and tell me what your question might be or what you're thinking of. So when you come to the appointment, you already have the questions or what you thought about or what's going on available to bring to the appointment. And if you happen to forget, guess what? Take a picture before you leave the house. We're gonna forget very possibly. Kind of give us some kind of tools to kind of work that right. So
Abs-
write it down and other things, take a picture.
Absolutely.
We had 2 comments. I think
Yeah,
you were
one
first,
comment
right?
right here.
I just had one comment. When we room for the physicians, we have the regular list of all the questions, and I always try to hit that one, because that's something that sometimes people will not bring up. And maybe they will if you say, are you having any concerns from this standpoint? And then I always take it to the provider with part of the main concerns.
Absolutely. If it's in that pre-clinic visit, it's in your note,
Very important.
then it's there for the physician to, or the provider to address.
Yeah.
I think you have a question. Yep.
Absolutely.
No, thank you. It's great to have a mixed audience, so we appreciate you
Yes.
attending.
Yeah.
And I think you have a question.
I was gonna say, I'm just clinical support staff, so I'm.
Not
just.
not just.
Not
You see, all of us jumped at the same time.
I'm not a provider, I'm not a nurse, I literally just sign
Thank you for that. Any other questions or comments?
I think we want to respect everyone's time, so we have 4 minutes. Any questions or any comments?
I have one last question, just to kind of wrap up.
Sure.
As being a first-time attendee,
Yay.
registered nurse.
Thank you for coming.
It's been wonderful, and I appreciate all that. And my last final question is, do you guys have any recommendations for the exam?
Well, yes.
I mean, it's still the fourth edition book, right?
Yes.
Yeah.
Yes, you can't go wrong with it, though.
Oh, yeah, yeah.
That's all I used.
Oh, gotcha.
That's all I used. I did do the practice questions.
Yes.
I used the book, the practice questions, and,
then this conference.
and this conference, yes, and definitely this well, back then, that conference.
Yeah, yeah.
And that's all I needed.
Okay.
Now, you could find other, at Barnes and Nobles, Amazon, I'm sure you can find other stuff out there that you could use, but that
I've
one
stuck
fourth
pretty
edition.
much to that.
Yes,
Okay.
yes, yep.
And we do recommend folks have at least a couple of years' experience, you know.
Yes, and I
just think it's
So
2.5.
do that, yes. Yes, perfect, perfect. And you know, you have the ability to go back to the other sessions that you didn't attend and look at those slides. Which, see, that's gonna be, if you think about how many days we've been here, and if there's topics that maybe you're not as strong on, immunology, things like that, you can at least pop on there and do that, so, so that would be perfect, yeah.
And the website has a lot of resources.
yep.
too.
Yes.
The IOMSN website has a taped session of fundamentals on it from a couple of years ago, Beth?
They are actually, we are audio recording fundamentals from this year. So yes, we've got the old one, but this session is also going to be, the 4 sessions are going to be recorded.
So you can
Yep.
go onto the website, iomsn.org, and you can watch again this session if you want to review that. And there's also lots of good resources on the website for you to study for your exam.
They're all free.
Yes. Perfect. Well, let's close our session, but I want to thank all of y'all for coming back and being with us. I want to thank our fabulous faculty up here. Just been a great group of folks. Do the evaluations and get your lunch to go. Safe travels going home, and we hope we see you in Phoenix next year. Thank you all.
Thank you guys for coming.
Thank you so much for coming.
Safe travels.
Thank you, guys.